Alrighty, folks, welcome to everyone for this month's LGBTQ plus health grand rounds. My name is Wei Chen Ling. I use she, her pronouns, and I'm the program manager for the LGBTQ plus health program. And we are so excited and honored to be introducing you all to Betsy Stickels and Dr. Brian Nuyen today. Before we get started, a brief housekeeping rules. We ask that you do stay on your muted mic while the presentation is in progress, and we'll reserve some time at the end for questions from the audience. So feel free to put questions in the chat or unmute to ask questions at that point. Because the session is being recorded, we'll be sure not to mention folks' names from the chat to protect your privacy. So please feel comfortable and safe putting anything in the chat. Feel free to also DM me as things come up. If you would like, captions should be enabled for your transcripts, so you can feel free to enable them on your end for your accessibility. And if there are any other accessibility needs we can help meet today, we would be happy to do so. By way of introduction, Betsy Stickels, MSCCC-SLP, and Dr. Brian Nuyen are co-directors of the Stanford Gender-Affirming Voice Clinic. Betsy Stickels, she, they, is a speech-language pathologist in Stanford's Laryngology Division, working alongside laryngologist Dr. Brian Nuyen to direct Stanford's Gender-Affirming Voice Clinic. Betsy started at Stanford in late 2023, and since then has developed 2 different free weekly groups for patients and community members seeking identity-aligning voice training, practice, and community, while also providing one-on-one voice training. Dr. Brian Nuyen, any pronouns, is a clinical assistant professor in the Division of Laryngology, Department of Otolaryngology-Head and Neck Surgery, specializing in vocal gender-affirming care, and particularly in procedures and surgeries as part of Stanford's Gender-Affirming Voice Clinic. Betsy, Dr. Nuyen, I'll turn it over to you.
Great, thank you so much. All right, so as I like to say, we're going to talk about something that we spend most of our time talking about today, which is identity aligning voice care. Dr. Nuyen and I are the co-directors of Stanford's Gender Affirming Voice Center, and I take on the training bit, and so we'll get started.
Yeah, thank you so much for having us. And this is meant to be an interactive conversation. The nice thing about the 2 of us co-presenting is if one person is sharing some ideas, the other person can always check the chat. So please feel free to chime in. We'd love to interact with you all and answer all your questions about this really important topic. And also obviously we're very biased, fascinating topic as well. Okay, so the question that we ask is, why would we want to, name our presentation identity aligning versus gender affirming? A lot of us here in the audience today are gender affirming care providers, or patients interested in gender affirmation care treatment, or folks who are interested in general with gender affirmation. But why do we use the word identity aligning?
Yeah, this is something I've recently started thinking a lot about, and it's due to how all-encompassing voice really is. We know from research that listeners intuit all sorts of things when they hear our voice, not just gender. And I think I think if we only focus on gender alignment, we're not really taking into account the entire person in front of us. And I think if we think about we're trying to find a new way of relating to the world, right? That's what we use our voice for, to send who we are out to the world. And so if we think of it that way, it's going to be much easier, I guess I could say, and much more intuitive if we take the entire person into account. I think every person probably feels they are more than just the gender they identify as, and I think voice should reflect that.
Absolutely. I mean, everyone here knows that there's no right or wrong way to be male or manly or masculine. There's no right or wrong way to be female, feminine, or womanly, and that this identity alignment is really key. And one of the things I really enjoy working with Betsy with is that she really gets patients to explore their identity, and it's a very identity exploring process. Because voice is so personal. We know that our voice, when we project it outside world, reveals so many things about ourselves that people perceive. And that's why working with you is particularly special, because I think you take attention to the whole 3-dimensional, 4-dimensional person in front of you and not just a gender binary.
So we are here to talk about voice. And for our purposes as voice experts, and how I know I approach thinking about voice, and just in general communication, I think of in terms of 3 different subsystems, and that's sort of how we will talk about the things we can train in a voice. So just a really brief overview. 3 subsystems of voice. We got the power source, so that's air in the lungs coming up through the trachea. They hit our second subsystem, the sound source, which is our vocal folds. They're housed in the larynx. The vocal folds open and close and vibrate to make the vibrating sound of our voice. But if we just had those 2 subsystems, we only sound like a duck call. We don't sound like a human at all. And so that's where the resonating systems, the sound modifiers, the filter of our voice comes into play. So as we talk through all the different things we can train in voice and speaking, this is sort of the foundation from which we work from.
Yeah, that's right.
Just a quick overview.
Yeah. If we think of the voice as generating pitch, which we'll talk about more in a moment, but really a single pitch is just a frequency, just a number of vibrations per second. And it's really the tongue, the palate, the lips, the gums, the teeth, the nose, the sinuses that shape that pitch into the billions of different sounds that we make as human beings and really express the full color, diversity, expression, emotion, character, stories that we all have. That really are beyond the fundamental frequency of the pitch number.
So when a patient comes to us seeking identity aligning voice training, our goal is to train one voice user, not one voice. And so I usually lay this out to patients as we want to give you the tools to kind of hack the system you have. We have so many different aspects of voice and communication that we can change. And as humans, our voice, our bodies, they're so flexible that we can achieve a lot of different options just with the parts we have. And so that's the big part of our goal. But for a lot of patients, when they come to see us, we're not even sure where we want to go. So that's the first job. Job 1 is deciding usually the question I will ask patients, and Dr. Nuyen has heard it many times, is asking patients, well, what do you want people to hear when we're all done together? That idea of, we've all heard someone before we've seen them and said, oh, great, Brian's here, just from the sound of their voice. And so when people hear your voice, what sort of things do you want them to hear?
Yeah, exactly. Like it kind of goes back to the original point a little bit about a lot of patients when they discover this intrinsic, authentic masculinity or femininity or gender fluidity, they come to us kind of with these broader goals. But I think one of the great things that we take pride in here at Stanford is that we don't take a template of femininity or template of masculinity or template of gender fluidity for these patients. We really kind of have the patient or, the person in front of us explore, like, just for example, like, a Scarlett Johansson type of femininity, a Ariana Grande type of femininity, a Cinderella type of femininity, a Trinity from Matrix kind of femininity. That's just an example of so many different variants of expression that we want to express to the world and the personality that we want to project and the way that folks want to hear us. And so we do a lot of exploration that Betsy really directs here.
Yeah, a lot of just trying things on, seeing what we find.
Yeah.
I've talked a lot about there's so many things that we can change in our voice. So here's kind of the way I will approach this idea is I like to think about our voice that we use for communicating as sort of a mixing board. We have so many aspects we can change with training. And we will go over most of these throughout the course of our discussion today. But there's resonance, there's voice quality, there's articulation, the way we shape our words, there's pitch, but then there's also what we do with pitch when we're talking and how we use it to underscore communication or how we don't use it to underscore communication. And so kind of thinking about each of these aspects as its own independent variable that we have control over gives a lot of opportunity for customization. And like we were discussing before, really moving beyond any sort of like binary rules. Like, it's really about identity. It's really about there's no box, there's no bar you have to cross, no threshold to reach. It's really building something that is you.
Yeah. And something, as Betsy's, work partner here, a lot of patients that I interact with that have worked with Betsy, the commentary I get from them is that this process is really fun because they get to play around with these different variables. What is it like when I work with an expert like Betsy who can then brighten the resonance, which we'll go over in a second what that means, darken the resonance, make the resonance velvety, make the resonance crystal clingy like Tinkerbells in a chandelier. What about articulation? What if we over enunciate all the words? How does that make me feel, most importantly? And also, how does that make me sound like to the average American public person? Because we know that what we project out to the outside world, we want to be perceived accurately. And that's true for not just these 5 dials on the DJ mixing board for your voice, but so many different dials. These are 5 of probably the most famous or most common ones, but really an infinite number of dials that we can work with and explore when you're in training with us.
So fun.
Yes, which is
I
really
also have a great time.
We're a little biased. So yeah, pitch. I feel like a lot of us, when we think about gender, the first thing we think about in society is pitch. We think male masculine voices are lower. We think female feminine voices are higher. What does the research show about this?
Yeah, so some interesting work has been done kind of compiling what we have learned about how listeners perceive gender from a voice. And latest data shows that pitch of the voice, or that envelope, it's really never just one pitch, really only accounts for about 40% of what listeners cue into when they're making that decision about who's talking to them. And if we think about it, that does make sense, because if we look at like research established norms for pitch, there is a huge area of overlap. Technically, according to most norms, speak in a masculine range, but I don't think people hear me as a masculine speaker, because I have these infinite other things in my voice that are tuned to reflect who I am.
Yeah, an example of this is my pitch is squarely in the masculine register. If I talk up here in this higher register up here, which if according to a computer would note that it is more in a feminine pitch, I clearly do not sound feminine. And I sound quite strained and actually in pain a little bit too. And so we know that pitch is just a really small variable when it counts for things like the way that people perceive us. It plays an important role, 40%, but it's not the all-encompassing variable.
A pitch is, fortunately, like so many other things in our research we've talked about, it is very mutable within one body.
What do you mean by mutable?
It's changeable.
Yeah.
Like one speaker will cover an octave plus while speaking, but then are capable of potentially, in some cases, an octave above that and an octave below that. So one voice is capable of living in many different pitch areas. And then we also, I actually lost my train of thought. That's all I have to say.
No, but key thing with pitch is that we think a lot of us think that, especially those who don't come from a musical background, don't have a lot of practice or prior life experience of changing their pitch or exploring the full power of their voice, are confronted with this unfortunate self-limiting belief that their voice cannot do that much, or that their voice kind of sits in this single place and it's unchangeable, and it's like the shape of their finger or the shape of their ear. They cannot be altered. But truly, there are 8 different intrinsic muscles inside the voice box, embedded within a whole neck musculature that is entirely changeable and is very facile with exposure and the unlimited belief that our voice truly can be accessed in a lot of different ways. And with in our experience, we really cheer our patients on and really emphasize self-compassion and self-confidence throughout this process, because we know the voice and the throat is an incredibly emotional organ, that all of these things are very rehabilitatable, very changeable, and within the reach of our patients.
I think one of the slight limitations is pitch, more than anything else we've talked about today, is tied to biology. So while we have been talking about how much change is possible within this system, there are going to be some upper and lower boundaries for each voice. And also, of all the things we can train a change in with the voice, to my mind, pitch is really the only one that results in greater effort, greater muscle effort to continue long term. For some patients, this is not an issue. We can train a better voice in a place that feels good and authentic and reflects who they are. Some patients find that this is a little bit too hard to get to stay to. It's a little too much effort. And that's where I, the trainer, will call in reinforcements. In the form of Dr. Nuyen, who is our surgeon.
Yeah, so like Betsy said, these procedures really affect pitch and pitch only. They don't modify the other 60% of what we know accounts for the variance related to gender perception and expression in the voice. Things like resonance, articulation, melody of speech. These surgeries do not affect that. But this is really just focusing on the guitar string itself. How do we surgically manipulate mass, tension, and length? Because we know the lighter the mass, the greater the tension, the shorter the length, the higher the pitch. Again, we know that pitch does not equal femininity or masculinity, but it's just a matter of a fundamental frequency. We know the thicker the string, the longer the string, the heavier the string, the lower it vibrates. And so as a surgeon, as a physics manipulator of anatomy, what I can offer these patients is ways to alter the pitch, especially if they run into the cognitive load or the effort barriers related to maintaining a pitch despite what they can achieve through training.
Yeah, I think the most important, well, I'm very biased, but the thing I want everyone to take away from this piece of the discussion is that none of these procedures can happen in a vacuum. They account for really a very small piece of overall voice character. And so they can be useful or even essential for patients, but I think it would be really irresponsible to sell it as something that can happen in a vacuum.
Yeah. We know that surgery can manipulate the voice box in terms of pitch tremendously, but the voice is not like an eyelid, and it's not like the shape of eyelashes or the shape of the lips. The voice is entirely functional as well as anatomical, and addressing the functional piece and particularly rehabilitating after surgery. For example, no orthopedic surgeon will operate on our hips or our knees or our shoulder without physical therapy. And so going through the rehabilitative process after surgery is also really important. So what are these pitch altering procedures to begin with? In this presentation, we don't have time to do a deep dive into a lot of these surgeries. There are some resources out there that this LGBT Health Plus Health Grand Rounds group has put out already, and you can of course reach out to us anyway throughout this process for more information about these surgeries. But for feminization, for pitch elevation surgery, not specifically feminization surgery, but pitch elevation surgery, the main surgery that we offer here at Stanford is called the vocal fold shortening retrodisplacement of the anterior commissure. Very long, wordy way of saying we shorten the vibratory length of the vocal folds, and we tighten the vocal folds as well, like tuning the guitar string and decreasing the mass of the guitar string as well. And so you can see on this intraoperative view of the vocal folds, the left and right vocal folds are on your screen, that upside down V. In panel B, you can see that the vocal folds have been de-epithelialized, which means the outer skin lining of the vocal folds has been removed. And in the final image, you can see that their stitches have been placed to basically create this web or this scar that shortens the vibratory length, decreases the vibratory mass, and because the stitch is rooted in underneath the vocal folds, it tightens the vocal folds and increases the pitch. And so this surgery we offer to our patients as a way to elevate their pitch. And after the surgery, before surgery, they kind of, after conversation with the patients and getting to understand their goals and needs, we offer the surgery to any patient who wants them, given that they understand the risks and benefits of this procedure. And before surgery, they get to know their voice box, to develop that awareness and understand their goals with Betsy. Because we know, like we emphasized at the beginning of the presentation, there's no templates that we work on in terms of femininity or masculinity. And then after surgery, they work exclusively and extensively with Betsy to rehab their voice and to get the voice that they want after surgery that are non-pitch related, those non-pitch related factors to really tap into, because again, this is a pitch adjustment surgery.
Yeah, and also, as you can maybe imagine by seeing this image, there's a fair amount of just reacclimating the patient to a new system here. Those first two voice subsystems are impacted. The vocal folds are a different shape. The space between them is a different size, so air is going to move through them differently. And so that's another big part of the post-op recovery as well, along with training and finding all the identity pieces.
Yeah, absolutely. We'll just take some time to answer just a couple questions here. One question from the audience is, with pitch altering procedures, is there any concerns about speech problems or dysphagia 30 to 40 years down the line? Speech problems, not necessarily. Speech, we know, a definition of speech is the articulation, the funneling of the pitch waves from the vocal cords into discernible sounds or phonemes. And because the surgery does not affect the tongues or lips moving forward long term, there are no concerns with speech down the line. So people actually with speech impediments before the surgery still actually have speech impediments after, or if they have a British accent before the surgery, they will still have a British accent after the surgery if they still want it. So great question. And dysphagia or difficulty swallowing, really none of our patients and none of the patients that we know of have difficulty swallowing, because even though the throat is kind of, we think of as one particular organ in the body, the throat that specializes in swallowing and the throat that specializes in voice are actually two separate areas, and we do not alter or disturb or do surgery on the swallowing food pipe portion.
Yeah, and this is really localized, really housed right in the vocal fold. So it's not going to impact laryngeal movement or anything like that at any point. There's no reason for it.
Absolutely.
I think if looking long term, the vocal folds have a life cycle like every other part of our body. And so they will change over time, which could result in a change in how the voice sounds overall.
Absolutely.
But that would be expected with or without this surgery.
Absolutely. That's a great point. Thank you, Wei Chen, for linking our information in the chat. And another great question, what is the minimum age for the surgery? We don't necessarily have a minimum age. It's a conversation that we have partner with for patients under the age of 18 to speak to their decision-making capacity, as well as in the context of supportive guardians who are invested in the well-being of that child. And so no particular minimum age. We can run it into insurance issues with surgery, but regarding voice therapy, which we know, spoiler alert, has no risks associated with it. We know with surgery, there's always a risk of bleeding, infection, injury to neighboring structures. With voice therapy, there's no risks associated with it, so that can be beneficial. And great question about growth. I probably would not offer this surgery for patients planning to go through puberty and not on puberty blockers. We know that with exposure to endogenous or exogenous testosterone, the laryngeal cartilages grow larger in an anterior posterior dimension, and the thyroid cartilage enlarges, and the vocal folds also enlarge as well too. So folks who are on puberty blockade, and this is a multidisciplinary discussion that we have with the endocrinologist, the primary care doctor, any surgeons who are involved with endocrine surgery for the patient, about the timing for this, because we know any exposure to testosterone to the voice box does alter and changes. Estrogen actually, we're still understanding the biological receptors related to the transcription factors of hormones within the larynx, but there's pretty strong evidence that testosterone, either endogenous or exogenous, has pretty profound impact on the larynx. Estrogen, not so much. So that's a conversation we have with the endocrinologist, the patient themselves, of course, and any supportive guardians who are involved in legal decision making. Okay, and then what about for masculinization? Can you talk a little bit about this while I get my laptop?
Yeah. So in our clinic, we have been using this quite novel approach to pitch lowering. What research has told us is that for even patients on systemic T, there are 20% who are not happy with the voice change they are able to achieve. But we also have a large portion of patients who do not want the effects of systemic T, but do want voice change. And so for those patients, we have moved towards providing direct injections to the vocal folds of testosterone, based on a case study out of UCSD a couple years ago. And that is done in office. Again, in conjunction with therapy, because this is just lowering pitch, making the vocal folds open and close fewer times per second. But we wanted to share an example of of a patient that did not undergo systemic T, but elected for just the direct testosterone injections.
Yeah, so this patient has consented to provide their voice recording for us. This is a recording before surgery, before the series of testosterone injections here.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch, which, with its path high above and its two ends apparently beyond the horizon.
Yeah, and so after a series of testosterone injections, we typically do 4 injections spaced over the course of every 2 weeks. So over the course of 2 months.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
Yeah, and I love, yes, thank you, Wei-Chen, for the thought. We love this rainbow passage for many reasons. And yeah, this is just an example, but we have probably a case series of about maybe 10 or so patients.
10 now, yeah.
The majority of which are patients who are non-binary or transmasc, but do not like the idea of systemic testosterone side effects, like Betsy mentioned, male pattern baldness, acne, bottom growth, muscle fat deposition changes, mood changes. And so, yeah, these treatments can be quite helpful. We also received another question privately about these testosterone injections as a result of, does this plump the vocal folds by the sheer mass of the injection versus changing the musculature or the cellular level? Long story short, we don't know. We haven't done the histological studies of the closest would be animal studies to study this on a histological basis. But we know that testosterone, I dilute it in normal saline, and normal saline dissipates in a matter of seconds when it's ever injected. And so I would venture to guess, while I don't have the definitive histological evidence, that plumping is not the main effect. That I think there are discrete cellular, epithelial, and myoepithelial and muscular changes that we know testosterone can affect on a transcription factor basis. Regarding the duration of these effects, this study that you see on the screen here followed patients up to 6 to 12 months. We are about a year out since we've been doing this, and the effects so far have been durable for the first patients that we've been seeing, so that's been great. These injections are covered by insurance for the most part. We're lucky that Stanford accepts many different types of insurance. And another person had asked this question, are these treatments, both surgical and non-surgical, available to those who don't want to undergo gender-affirming surgery? I'm guessing that question comes from a cis perspective, like if these treatments are available for folks whose gender identity matches those who are assigned at birth. Yes, in general, they are. We, center our trans patients because we want to make sure that their gender affirmation needs are met. But for cis folks, get voice therapy all the time to sound more leader-like, more feminine, more masculine, etc. So we know gender-affirming care, and this audience knows, is also commonly used among the cisgender patient population as well, too. So, or hypothetically trans folks who have no surgical plans. Absolutely. Yes. So yes, great question from another audience member. All of these are open to anyone and everyone. Yes. So yeah, moving on here. This is an example of our protocol, and this is the voice recordings that we have here of the amount of testosterone injection, which those who are endocrinologists or primary care doctors who prescribe, just FYI, we do give 25 milligrams of testosterone into each vocal cord. And as for safety measurements, we draw weekly testosterone levels for our patients undergoing this, because a lot of these patients do not want spikes in their serum testosterone, so we measure their serum testosterone as a safety measurement as well, too. Okay.
And the thing about vocal folds is they're quite small and not well connected to the rest of the body.
Yeah.
So when we put things in vocal folds, they tend to just stay there.
For those, exactly, for those in the audience who are otolaryngologists, or we know that the larynx, the glottis itself, the two vocal cords, have very poor lymphatic supply, which is why outside the scope of this talk, folks who have glottic cancer do not experience as much metastatic spread of their cancer to the lymph nodes in their neck compared to the supraglottis or the subglottis, because the lymphatic vasculature and connecting tissues are the glottis is poorly connected to the lymphatics in the neck. And so that's the reason why we think it's difficult to treat laryngeal candidiasis, why these testosterone injections do not cause a systemic testosterone level, because the blood and the vascular system has a hard time accessing the glottis, for better or for worse. Moving on, we'll talk about resonance here.
Yeah, so resonance is one of my favorite things to talk about, though it is the least straightforward. It's sort of like the magic that happens with voice. It's everything that happens with the voice once it leaves that simple vibration of our vocal folds. So everything from the vocal folds to your lips, it does a lot to shape what our voice sounds like. I think an analogy that is useful to think about sort of the role of resonance and what it can do for our voice is thinking about the stringed family of instruments, particularly this progression here of violin, viola, cello. They're all played similarly, they're all shaped similarly, but the sizes are different, right? And a cello is going to sound much lower than a viola, which is going to sound much lower than a violin. Same thing with our voice, regardless of, and the reason why I guess that there's such overlap in terms of pitch and why pitch can only account for 40% of what goes into making that decision about who we're listening to is this role of resonance. So vocal folds that are vibrating at a rate of 175 hertz, which is sort of in what research will call like the gender neutral range. It's part of that area of overlap. That fed through a relatively small, relatively short and narrow system is going to sound higher than that which is being fed through a larger, longer system. To really dig in with this analogy a little further, I learned today that violas use the same strings as cellos. So the exact same strings, but they have a smaller resonating body and they're played more like a violin. So that's what accounts for the differences there. Resonance is also where we get a lot of the things that we would fall under voice quality. So that could be like a rough voice or a smooth voice or a bell-like voice. Some areas that we talk about a lot in this work are the idea of make it clear. Okay. The idea of a bright sound to the voice versus a dark sound to the voice. And this is something we all know innately when we think about vowels, right? And this is usually how I will think about it and teach it to patients, if I teach it to patients. The idea that E is our brightest vowel, A is our darkest vowel. So in the course, if I take the pitch out of my voice and I just blow air through an E-shaped system versus an A-shaped system, it's going to sound interestingly higher, right? If I do versus there's no actual voice there, but sounds lower than and that's because the A is darker, the E is brighter. Similarly, my personal favorite party trick is if I keep the pitch steady and morph from E to A, you can really hear that change. And I will do that for you now. So, pitch was the same the entire time, but I really just played with that resonating track. And we can train towards a more E-like shape or more A-like shape to really affect a lot of so brightness would be things we hear as like that pingy, ringy quality, that bell-like quality, Kristen Bell is a really good example of a bright voice, whereas Scarlett Johansson is actually a really great example of a darker feminine voice. And so just to kind of imagine those two different sounds in your ear there. So that's something we can tune regardless of whatever else is in play.
Again, same pitch, completely different sound, secondary to resonance. Yeah.
Other qualities we often talk about are heavy versus light, so or voice weight. A heavy quality can come from a lot of different things. It can come from the amount of tone we let come through the voice. So if you're familiar with musical terms, like if you think of like a Western musical theater tradition belt, that TA, the vocal fold, the muscle inside the vocal folds can activate and give us a more squared up vocal fold closure. So we can get a much thicker, stronger, boomier sound that way.
What would that sound like?
Not pretty in my voice. It would be like an ah, that really like brash, like I'm not going to do
Brassy.
it again kind of scene. In my very small, narrow system, it does end up being quite brassy. Versus like a falsetto would be more turbulent air through the system, less vocal fold contact. We really just have the edges, the vocal folds closing. So that's one way I think of heavy and light. The other way we can manipulate this, and we'll talk about this a little more later also, is the pressure buildup for consonants in terms of articulation. And so that is which is coming up.
So the next topic is manner of speaking, which is melody of the voice, rhythm while talking, the rate at which we talk, the enunciation, our nonverbal communication. All of these are deeply gendered and also reflect all these different aspects of our identity and our mood, and also things that we cover here in our voice center as well.
Yeah, so one of my favorite things to work on is pitch variation or the melody of speech. And there's a spectrum here. I like to think of one end as like that cartoon caveman, right? Kind of monotone, very telegraphic, very bop, bop, bop. So like fire, good. Or like a children's entertainer, right? Where there's lots of ups and downs, there's lots of animation there, like good morning, boys and girls. So that's one parameter we can work on, right? And I think that's important. And that's where we can bring in a lot of personality aspects. This is probably one of those things that we innately change all the time when we're talking. Just for instance, I'm talking to you all different than I would talk to my wife, different than I would talk to my patients. And that is a context switch, right? And so that's primarily seen in this idea of melody, pitch variation. There are also things we have to take into account when we're talking about changing voice, is we need to preserve the things that sound natural. So there are conventions that people are used to hearing, and we may not notice when they're there, but we notice when they're not there. And the pictures I included here are some people that have made entire careers out of switching up this expected convention of melody. The very monotone Ben Stein, Christopher Walken doing his walking thing, and then Julie Andrews, who is just, I think, delightful in every way.
Yeah, and so we really customize this to our patients. You know, we always ask, like, how do you use your voice? Are you in construction, have to yell across the field? Are you a kindergarten teacher and you have to engage children in the quality and the interest in your voice? Do you primarily not talk at all? Are you a performer, an opera singer? We really, really customize this to what the patients want and how they use their voice on a daily basis.
Yeah, and so this plays right into articulation, which is, I really think about, so resonance is vowels, basically the vowel sounds of what we say. That's where the musicality is. Articulation is basically the consonant. So when we talk about articulation, we're talking about all the places that come together. So we can just go there. And there's some level of pressure buildup. And this does a surprising amount for changing how a voice is heard. I think one way to really think about this is combining it with this sense of melody. And there are some really strong biases in how we hear this. If you think about like a very punchy kind of manner of speaking, like I usually liken it to like a used car salesman. So like, have we got the car for you? And right, it punches out a little bit more versus what tends to be a little more masculine perceived, versus the more feminine perceived would be those, instead of punching out, we're swooping up and down. So have we got the car for you? That it has smoother lines. There's less pressure buildup in those consonants, and the voice can just sort of flow in a more melodic way, versus that punchier, more telegraphic, high pressure buildup on those consonants. It can do a lot to really change that, the way a voice sounds when we're talking. There are other aspects that are less directly related to voice, but fall under my purview as a speech language pathologist. These are things that I think I mean, I know everything we've talked about. We have said this is based on identity and personality. I think these things are the most. And a lot of patients come to me with these things kind of in place. So I don't make it my business unless I'm asked to. But these are things like facial expression, word choice, gestures, posture. Those all sort of fall under the purview of identity aligning voice training.
Yeah, absolutely.
So just as like a wrap up, I think what I would like everyone to take away from this, and you chime in too, Brian, is that, you know, our job here in our gender affirming voice clinic is giving patients tools to hack their voice to reflect who they are. I look at my job as a facilitator. I don't decide where we're going. I don't decide the final product. I just help you, the patient, get to it. And it's a lot of fun. We have lots of tools and lots of options. If we get stuck, the nice thing about being within our clinic, our program here, is if a patient gets stuck with that pitch piece, we have alternatives that we can take to the surgeon.
Yeah. Yeah, and I think something that we take really pride in at Stanford is that there are a lot of voice training programs out there that offer a lot of resources online to a lot of transgender and gender nonconforming folks out there. And something that we really take pride in here at Stanford is that we personalize the experience, and we're really anti-algorithm.
Yes.
You know, a lot of patients come in expecting that they have to, you know, take a test or fit XYZ process so they can be perceived as feminine and kind of get this process under the belt. But it's kind of like, I think, when we as trans people or gender nonconforming people explore fashion, you know, it's really a personalized process that involves trying things on, playing with it, saying that, you know what, oh, I don't like that at all. Oh, actually, this feels really cool. I feel most myself. I feel most powerful, friendly. The best parts of my personality come out by wearing these types of clothing. Same thing we do in our voice clinic here. And so we really take pride in this pro-individual anti-algorithm approach that really personalizes everything, that takes sometimes a combination of surgery and therapy, sometimes just therapy, but Betsy and I collaborate deeply on every one of our patients that that really kind of help patients feel at home in their voice there. So yeah, how can you find us? We have a joint clinic in Emeryville. We are starting a new Redwood City clinic. I know a lot of folks in our audience have been great referees to us and have been sending us a lot of referrals. And these patients have traveled so far, especially if they come from like places like Sunnyvale. Good news is that we're opening a clinic in Redwood City where Betsy and I get to see our patients there in person that are focusing on transgender voice. We have frozen these clinic slots specifically and prioritized our transgender, gender nonconforming patients so the wait time is minimized as much as possible because we really center and prioritize their care. Good news is training can be done in person or via telehealth, so these patients can come from very far away and still get the care they need. And the great thing is that what's quite innovative also here at Stanford is Betsy is one of the very few people, if not the only person I know of in academic laryngology, who has gender-affirming voice group therapy, which is an incredible resource for these patients, which is free. These patients can come without any insurance and in these safe spaces, surrounded by gender nonconforming folks, and play around with their voice in a safe setting. So they can say like, hey, you know what? I tried this thing that we worked on last week about making my resonance, you know, darker, and I went to Starbucks the other day and did it, and they asked, you know, they use my correct pronouns just based on my voice, and we get to celebrate it together, and it's a really fun experience there. So if you're interested in this group, please have your patients email Betsy at the email listed here. Otherwise, we're here to help. So just let us know how we can help anyway. Okay.
Absolutely. Thank you.
We wanted to reserve some time for questions. So yeah, we'll go ahead and stop sharing our screen here. And yeah, just catching up on our questions here. We said, yes, these treatments, both surgical and non-surgical, available to those who don't want gender-affirming surgery. Yes, including transgender, non-conforming folks who don't want to undergo surgery. Absolutely. We have patients who the thought of the idea of any kind of procedure is just not at all what they want. 100% okay with us. We have lots of strategies to help them get their voice to how they want to be. With the political climate now, is there a way to be referred to your clinic without vetting as THNC in the medical records. Yes, I think we have our goal is to get you the care that you need,
Yes.
and we won't let other systems in place try to get in the way. And I know that sentiment and that core value is shared by so many of our Stanford gender affirming care providers. So yes, I think talking to your primary care doctor and having that primary care doctor maybe message us directly on ethics so we can look out for the referral and we know how to look for it, and then reminding us again in the encounter to not use gender dysphoria as an ICD-10 code. Lots of ICD-10 codes or diagnosis codes we can use to help get you the treatment covered that you need covered.
Yes, and the good thing about voice training is SLPs only have one code, whether we're fixing R's or working on language after a stroke, it's all one code. So no one ever has to know what we do.
Yes.
And so I rarely use a gender. I have a non-gender related code that I'm able to use for diagnoses as well.
Another great question from an audience member. I had a question about, thank you for the kind words. We had a question about voice surgery recovery. I heard that the recovery time for VFS RAC or pitch elevation surgery is 2 months, which is a long time to be able not to talk. Is this a similar time frame for your clinic, and do you have any suggestions for communicating during recovery? Absolutely. So my fellowship director actually is Dr. Hyung-Tae Kim, who invented this procedure, and I brought it from South Korea to Stanford, to the US. And with our algorithms here, with our protocols here in place, Betsy and I have really tried to minimize the impact of recovery on patients. And so we have actually a period of strict voice rest that is right now about 2 weeks. But depending on the recovery process, we see you for post-op at the 1 week mark after surgery. And if things look good, we have you start talking at the 1 week mark. Yeah.
I would just say that, like, yes, I personally want patients using their voice.
Same.
Yeah, I know you do too. Sorry.
Yeah.
Using their voice soon. We know that can impact healing. We know that it's just harder to get the voice going the longer you're on voice rest. But I will say, whether a patient's on 1 or 2 week of voice rest, I will follow them quite closely afterwards to kind of guide them back into talking. Maybe 1 week, maybe 2 weeks of like a vow of silence, and then 1 to 2 weeks of guided getting back to talking.
Yeah, and we, not to belabor a point, but we personalize the voice rest period to based on your goals. So if you are an opera singer, we help provide the supportive paperwork and talk to your, work to your employer so they know that you are on this voice rest period. If you, during the modified voice rest period, which is the 2 weeks afterwards, you need access to amplification. We provide the necessary medical documentation for your workplace to provide voice amplification. People get around this by using their texting apps that we have lots to recommend, as well as a whiteboard, things like that can be helpful.
And that's part of my pre-op counseling too, is getting patients set up for success, because it is such a reflex to want to talk and answer family members, for sure.
Yeah. And another question we have is, could you say more about the approximate cost for the voiced sessions? By voice sessions, I'm guessing the voice therapy sessions.
Yeah. I don't know. Fortunately, insurance typically covers the care that we're able to provide here. So I don't know exactly what that is like. So it really depends on a patient's individual plan and coverage. But it's probably a small handful of visits, between 6 to 10 if we're going to do surgery, probably more like 10. So whatever their insurance says times 6. I wish I could give actual dollar amounts, but I am left out of that conversation.
Yeah, we obviously want to minimize any out-of-pocket costs for our patients, so we really we push hard for insurance coverage, and I would say for the vast majority of times we are successful. Yeah. We're grateful that Stanford accepts so many different types of insurance. For cash pay patients who are not citizens of the US, for example, it's a case-by-case basis. We work with them to really, again, minimize the out-of-pocket costs, because gender-affirming care should be a right and not a privilege that's based on financial resources. Another great question for providers outside the Stanford system: is this the best way to refer to patients self-refer or have the provider connect with you first to facilitate? So, Dr. Del Castillo, thank you for that question. I'm assuming you're outside of the Stanford network. Number one, thank you for being here. Number two, this is for Dr. Del Castillo as well as the other members of our community here. If you are a provider interested in connecting your patient and worry about your patient getting lost in the mix on their way to Stanford, please directly email me with a secure prefix to the email so that I can work with our team to shepherd the patient across the chasm of insurance and referral networks and the billions of middle persons along the way that may make things worse instead of getting better. Our goal is to help facilitate, open the doors, get access through, especially in times like these where we worry about, access and the political environment. Our goal is to break down barriers, and so you can please directly email me referrals, obviously with a secure attachment for HIPAA compliance. But our goal is to minimize barriers to access. Thank you, Craig, for those kind words. Thank you, Lynn, for those kind words as well. Any other questions from folks here?
There were a couple of questions, and thank you so much, Betsy and Dr. Nguyen, for this great presentation. The engagement is proof in the pudding of how much this topic is needed and how much this information is welcome. There were a couple of questions earlier around the direct testosterone injections. One question that is here in the chat, let's go back up to it. Is it typically something that's covered by insurance?
Yes. So far, for the past year, we've submitted these codes and we have not run into insurance issues. I think there was one patient that might have had an insurance issue with one session of voice therapy with Betsy, but we work through things on a case-by-case basis. So
all the injections were covered. Just my silly little visit.
One visit was not, the insurance company didn't have, but we ended up speaking with them, and part of our title as co-directors of our voice center are advocates, so we definitely make sure to minimize barriers there.
Absolutely. Yeah. I think that's our primary goal, is that patients can get whatever voice care they need from us as easily and efficiently as possible.
And one of the things that we're very grateful for is that we are part of the Stanford LGBTQ plus Alliance. So we're fully aware of the really incredible people in this chat, in this audience here, who are all stars, and we're so grateful to partner with, that we refer to, and patients casually mention, I'm looking for to learn more about bottom surgery. Hey, I'm looking to establish primary care. I'm looking for facial feminization resources, looking for a good endocrinologist, and we're like, we have some great folks that we work with, and we are able to connect them too. So we're lucky that a lot of these folks are here. Wei Chen and Blaze are fantastic leaders in our organization. So grateful that we're all part of the same team.
Yes. Absolutely.
As am I, as always. Another question around the direct vocal fold testosterone injections was, how long do their effects typically last?
Yeah, we are coming up on 1 year for one of our patients who first started doing this on, and they have had durable results. We have every reason to believe that the effects of testosterone are fortunately or unfortunately permanent. And it's a powerful transcription factor that makes every muscle in the human body thicker, longer, heavier, including the muscles of the vocal cords themselves. And we know thicker, heavier, longer strings vibrate at a lower frequency, and those effects seem to last. Betsy did mention that our voice boxes do have a life cycle and change with time. Over 10, 20, 30 years, our voice sounds different because our vocal cords, as the rest of our body, changes with time. But that's a separate effect from testosterone. Yeah.
Understood. Got it. If there are any more questions from the audience, feel free to type in the chat or feel free to come on the mic. We'll just ask that you use the raise hand emoji so we can see when you do that. And while folks are doing that, just also want to quickly plug, if you liked this session and want to continue staying tuned on our LGBTQ plus health programs monthly grand rounds, I'm going to drop the link to subscribe to our monthly newsletter in the chat as well, and welcome anyone internal or external to Stanford to stay tuned and join future grand rounds. I see there's another question in the chat here. For testosterone injections, does that get funneled into the national tracking for testosterone as a controlled substance?
Yeah, I am. There's two main ways that we administer testosterone. One is I prescribe the testosterone to the patient's preferred pharmacy, and they bring the bottle of testosterone to the visit, which I then aliquot, dilute, and then inject. Or in Emeryville, we have a pharmacist actually that dispenses the testosterone. And both methods are controlled substances. So I imagine throughout the process, because it's a controlled substance, it is part of the national tracking, fortunately and unfortunately. So yeah, that's a good question there.
Any other
Any other questions for us? So the
about the
structure.
structure of
Oh
the
yeah.
free? Oh, yeah, yeah, yeah. So there's two different groups. One group is very loosey, very goosey. It's been in practice for years now. I think two members celebrated Christmas together recently, this past year,
It's really
because
cute.
they didn't have family to celebrate with, which was really lovely that they had each other. That one's very conversationally based. It's sort of whatever comes up, we talk about, people practice. I'm there to offer insights. But it's very loosey, very goosey. Wednesdays are a little more structured. This is a newer group, the Wednesday group, and so I still fairly loosey, fairly goosey. I Whoever shows up, they're meant to be drop in nature. I sort of ask what people need help with, what's on people's mind, and we go from there. The conversation moves from there. But it's been really nice in that I have all different levels, some that are finished therapy, they're done, they just like to keep coming. Some that are just starting or are not able to do individual therapy, and there's a lot of opportunity where I don't have to be the authority in the room. So there's a lot of just like note sharing, and this worked for me, that worked for me. And so there's not a lot of structure. It really just depends on who shows up on any given day.
Thank you, Blaze, for the kind words, and thank you for all your work and leadership for our team here. We also wanted to mention that there on May 1st, one of our colleagues, Dr. Seth Davis, who does provide gender-affirming facial surgery, facial masculinization, facial feminization, Adam's apple construction. I also work with him on some of our chondrolaryngoplasty or Adam's apple reduction surgeries. Has a facial plastics open house on May 1st. At 2585 building in San Jose, the Stanford San Jose building. And it's open to providers in the public. So if you're interested in going to that, feel free to check out Dr. Davis's gender affirming work there too.
Okay, thank you.
But yes, we have our contact information. Please reach out to me. Please reach out to Betsy. Let us know how we can help. We love direct messages from our teammates, from our fellow care providers here to help shepherd things. So thank you. Really appreciate you all.
Yeah, thank you. This has been so fun. My favorite thing to talk about.
And we'll
Thank
be
you,
sure to
Wei-Chen.
send your contact information as well as that session for Dr. Davis out in the follow-up email as well.
Thank
So
you
I
so
know
much,
we're
Wei-Chen.
approaching time, so thank you everyone for being here. Thank you again, Betsy and Dr. Nguyen, for a lovely presentation. And please enjoy the rest of your day. Please take care. We'll see you next time.
Take care, everyone. Thank you. Thank you so much.